Okay, it's 2 minutes past now, so we're going to make a start. So once again, thank you for joining us for this section, which is on the microbial diagnosis of brain infection in low and middle income countries, these challenges and advances. We're so happy that you've made our time to join us. Just some few housekeeping rules. All right, so this webinar is being recorded and will be shared on the Global Health Network. So in case you want to revisit it, including our previous section, they are all in that web page. And then due to the number of participants, please, we do plead with you to turn your camera and microphone off, so disable them. Otherwise, it will just be chaotic. And use our chat function, which is available there if you have any questions. We'll have a sections where we're going to have the opportunity to answer all your questions. So please do keep them coming in the chat. And then we'll try to get through as many as possible of this question. But if we can't answer anything, feel free as well to reach us by email if you have any further questions. So this is just a snapshot of those who registered to attend this section. So we're so happy that we have a representative for all over the globe, and we're looking forward to a very resourceful section here. Thank you. And so so because it's a learning objective, you can obtain your certification if you want, and the details are there. If you want to obtain your certificate, you need to click on the link that is on your screen, and then fill in a few details to obtain that certificate. So once again, we're so delighted to have our speakers and our panelists that have joined us for this section to discuss about some of the challenges on microbial diagnosis of brain infection. So for today, we're going to have someone that is at the forefront of improving diagnosis of brain infection, especially in the LMIC setting, to chair our session. He is a clinical research fellow in the brain infectious group here at the University of Liverpool, and also an infectious disease general internal medicine and tropical medicine training fellow at the University of Liverpool. He's currently based at the Department of Medicine at the Queen Elizabeth Center Hospital over in Blantyre in Malawi. And he's at the forefront of leading the brain infections and global project, which is all about microbial diagnosis of brain infection. And he has collaborated with us formerly in the MRC-funded COVID Neuro Global Research Program, which was in the UK, in Brazil, India, and Malawi between 2018 and 2023. And Dr. Singh Bhagteshwar research spans a broad area from interventional studies to epidemiological and implementational research, evidence by synthesis aiming to improve and understand the mechanism and the cause of brain infections in low and middle income countries. So he has a huge experience and knowledge on challenges with regards to brain infections diagnostics. So without further ado, I'll hand over to our chair of today, Dr. Singh Bhagteshwar. Over to you, sir.
Thank you so much, Nathan. Thank you for the long, very complimentary introduction, and I'll just briefly take us through some points and then introduce today's speakers. So in terms of the challenges of microbiological diagnosis, I mean, some of this is not necessarily just microbiological, but just, when we were coming up with the idea for the brain infections global study and how it might work, we realized that this is complex. And that's what, the take home from this slide is that it's complex. But there are many processes involved. Some of those are influenced by time. Some of those require physical or material objects or something to be there, and some of them require capacity or capability of other sorts, and many things need to work in order to make a diagnosis. And those of us who work in healthcare or in health research, I think, know this concept broadly, but this is just to illustrate the complexity that there is. And just, a couple of examples. So when we're looking at pyogenic or bacterial meningitis, there's a problem in terms of people needing to be kept alive by early antibiotic therapy versus the need to find out which bug is causing the infection. This is just a conceptual diagram, I guess, of sort of saying, look, you've got this sensitivity, or maybe we could just simplify that to ability, maybe to make a diagnosis here, or for this to be positive. And both gram stain and culture have a reduction, maybe more so culture than gram stain, in that sensitivity after antibiotic therapy. And there are some studies that show the effect of that over time. And then PCR, however, and one of the things that might get around this challenge to an extent is newer tests, and PCR probably is much less susceptible to that effect of antibiotic therapy, because you might be able to detect dead or fragments of dead organisms, for example, within the cerebrospinal fluid. Similarly with arboviruses, again, conceptual diagram, no actual numbers on here, but many of you will have seen this and know that early in the stages of some arboviral infections, and probably best documented for dengue, the virus can be detectable, usually in the blood. How much of that actually gets into the CSF, and I'll let our speakers go into that in a bit more detail. And then there's an immunological response that can be detected through detecting antibodies in the blood or serum, as well as in CSF. And this just, again, I'm not going to go through this in detail, but you can see that some of these tests might just be positive because someone resides in an endemic area, and there can be cross-reactivity. There can be antibodies produced from vaccination and from recent infection that might actually not be relevant to the person's presentation just now. So what advances are there? And I'm kind of, with this slide, setting the scene for us to talk about advances that are already practicable, or already available, or will be available soon. And big movements really been made in terms of point of care tests and rapid tests, and rapid versions of, I guess, what we've just mentioned, serological tests and PCR. And there are lots of rapid PCR tests that are coming through, and multiplex, so looking at various targets or various organisms. And then next generation sequencing. This is a MinION or a nanopore device that's handheld and can just be connected to a laptop like this, to do some really high-tech work to try and find things that we didn't even suspect to be there in samples. And then host transcriptomics, and the Liverpool team and Mike Griffiths have been at the head of that, have been working on how to tease things apart in terms of the host immune response with various markers and not just antibodies. But as an overall approach, I think it's understood in places with lower levels of resources. But I mean, this could apply to different parts of a health system that is even better resourced, that there are some core tests that probably should be done in everyone. And then depending on whether you find an answer using those tests and your availability, then you can perhaps use things that tests that are maybe a bit more expensive, a bit less available, and might look for a broader range of pathogens. And then you get to higher cost and more advanced tests that might not be available everywhere. And sometimes the patient will need to move for those. Just a few slides to briefly talk about this brain infections global project that Rafael will go into a bit more detail on in terms of how it worked in Brazil, and Tina also contributed to that substantially in India and did things alongside that. So this was a 4.5-year program that worked across various themes to try and tackle the issue of making a diagnosis in patients with brain infections. The work was mainly done in Brazil, India, and Malawi. We aimed to improve the diagnosis and also where we could, early management of people with possible brain infections. We focused on hospitals, secondary and tertiary care hospitals, and I think we've come up with a standard care package or toolkit that can now be used beyond where we worked. We looked at what was happening initially. We developed an intervention in a co-designed fashion with hospital stakeholders and policymakers, and then we tried to work out what had happened because of the intervention or alongside the intervention. It was a multi-center before versus after study. We had 13 hospitals in the 3 countries, and our primary outcomes were looking at diagnosis, one of which was microbiological diagnosis. I'm not going to go through the rest of this, and we can have questions later if needed. So we had a period of intense observation at the start in each center, and looked at what was happening in pre-intervention patients. We started to design an intervention and then actually implemented it as these blue boxes at the end. And the intervention contained multiple components. You can see this third one along here, the diagnostic testing panel, focused on microbiological diagnosis, but Rafael will tell us a bit more about how you can't skip the other steps if you really want to make a diagnosis. We found a range of pathogens, colors of the rainbow here, probably not enough time to go through them, but around 60% overall were bacterial, and therefore the vast majority of what we found was treatable, including some treatable viruses, parasites, and fungi. And here's just some characteristics of the patients that you can scan through. And the results were syndromic diagnosis. Maybe we'll skip. The focus of today is microbiological diagnosis. You can see that if this observed proportion of people getting a microdiagnosis were to carry on, assuming the intervention never happened at this dashed line, you can see these red dots. And then the actual observed line is above that, and therefore taking into account what the trend was that was underlying in across these 4 centers in 3 countries. This increase from 22% to 30% before versus after the intervention was significant. We also showed some improvements in other measures and in individual centers as well as overall. We have done some of the more advanced things that aren't necessarily usable just now, like next generation sequencing. We're awaiting those results, and we're now in a phase of disseminating results. You should see a paper very soon. There's going to be a toolkit that will be freely available online from next week, and we're feeding into national and WHO guidelines. Just briefly acknowledge everyone who's involved in that. But now it's my pleasure to introduce today's speakers. And I think, sorry, there's a formal introduction that Franklin will do, so I won't do that in much detail. But I've had the pleasure and privilege of working with and getting to know both of today's speakers really well. And so I've got some, cheeky photographs that aren't necessarily just, us standing in white coats somewhere. And when Tina has been in Liverpool recently, this was in a cafe when we finally got to sit down and have a coffee together. And here's Rafael on a site visit, actually. I did find Rafael a nice non-work picture, but I thought you might not want me to share you playing the guitar. And so we've got this picture instead where Rafael's actively taking us to different hospital sites as part of the project. Back to Franklin. Thank you.
Thank you so much, Bhagteshwar. So we'll now invite our first speaker, Dr. Trainee.
So first of all, thank you for that picture. It brings back memories. And thank you for the introduction. So my name is Damodar, and I'm an India Alliance Wellcome Trust Clinical Fellow in the Department of Neurovirology at NIMHANS, which is an institute of national importance in southern India in a city called Bangalore. I'll be speaking on microbiological diagnosis of acute brain infections, particularly acute encephalitis syndrome in India. So acute encephalitis syndrome, which is characterized by acute onset of fever with an altered mental state, with or without seizures, is an important public health problem over here in India. In fact, the National Vector-Borne Disease Control Program reports at least 10,000 cases of AES in India annually. And it predominantly affects children less than 15 years of age, mostly caused by infectious agents. Although this presentation can also be seen with toxic, metabolic, or autoimmune causes of autoimmune encephalitis. The term acute encephalitis syndrome was coined by WHO for a syndromic surveillance for patients presenting in this way. before we get into the microbiological diagnosis, I thought it's important to just go through the history of AES outbreaks in India to get a clearer picture of where we are right now. So as you can see, the first report of Japanese encephalitis was first reported from a southern Indian state called Tamil Nadu in 1955. Thereafter, between 1970s till 2000, there were repeated outbreaks in the north and northeastern belt, particularly in Uttar Pradesh, West Bengal, Assam. And it was, although we had other causes of encephalitis, that is Chandipura, Nipah, enterovirus, West Nile. However, till 2010, I would say Japanese encephalitis was in the limelight, complete limelight. So it was only after 2005 when we had a massive outbreak in UP where Uttar Pradesh, that is, where more than 6,000 cases of Japanese encephalitis cases were reported, and there were 1,500 deaths. After that, in 2006, the term WHO was coined by, the term AES was coined by WHO and NVBDCP, that is the National Reporting Body in India, started reporting and doing a very syndromic, systematic surveillance of JEV cases. In 2011, we started with single doses of SA-14-14-2, which is a vaccine against JEV, and it was included in the National Immunization Program for endemic regions only. In 2013, the program initiated 2 doses of SA-14-14-2. And while this was happening, repeated outbreaks of JEV continued. We had other causes of encephalitis also being reported, especially post-2010, where there were increased reports of scrub typhus, dengue, chikungunya, leptospira. However, this was not a systematic reporting. It was just reporting from few outbreaks. And as you can see here, there's toxin-induced encephalitis also. So all this, while it mimicked JEV, they were really not JEV. Oh, sorry. So yeah, so just to break this whole history, and before I get to my next slide, a poll question. We've spoken about JEV, I've spoken about JEV. What do you think is the standard microbiological test for diagnosing a Japanese encephalitis? Is it CSF anti-JEV IgM ELISA, serum ELISA, PCR for JEV in CSF, or PCR for JEV in blood? Yep, so it is CSF IgM ELISA, although there is reliance on serum IgM ELISA, but given that vaccination can produce antibodies, there is always a diagnostic dilemma. So as I said, that after 2010, particularly post 2015, we observed that there was a reduction in cases of AES due to JEV. It reduced to around 10 to 15% only. However, the cases due to AES continue to remain the same or even increase in certain regions. So the question that came up was, if not JEV, what? And that is why this 4-year enhanced surveillance study was initiated by a team in NIMHANS in the northern Indian states, hyper-endemic for AES, that is Assam, Uttar Pradesh, and West Bengal. They did this, they used a standardized diagnostic algorithm to test for causes apart from JEV. And they enrolled around 10,000 patients with AES. And what they found was, apart from JEV, scrub typhus and dengue virus were key etiologies. However, there was region-wise differences. As you can see over here in Uttar Pradesh, while scrub typhus was the most important cause, in Assam, the cause was JEV, either JEV or chikungunya. And in West Bengal, it was scrub typhus. That using an enhanced algorithm also increased the diagnosis and etiological diagnosis of AES to 3 times more than it was before using an algorithm. Therefore, we initiated a similar study in southern India in 2020. It is still an ongoing study, and it is through the India Alliance. We've been recruiting children from 3 tertiary care hospitals in Bangalore, and we have patients from this highlighted regions from these 3 states, although more from Karnataka. And any child meeting the AES WHO criteria for AES is enrolled in the study. We use an extensive laboratory strategy for detecting at least 18 to 20 pathogens. It uses ELISAs as well as molecular tests. So ELISAs for dengue, IgM, chikungunya, IgM, Japanese encephalitis, scrub typhus, leptospira, malaria, and then there is a whole PCR panel for bacterial and viral etiologies. We also are testing for tuberculosis on retrospectively stored samples. One addition that we have done is also performing CSF IgM ELISA for pathogens, which I will speak about in my next slides. So in the first 3 years of the study, the preliminary results are we included 589 children in the study in the first 3 years, and etiological diagnosis was achieved in around 54%, and scrub typhus is the most important cause of acute encephalitis syndrome in this part of the country, with 21% of overall and around 50% of those who have an etiology, who have a microbiological diagnosis. The next common etiology is co-positivity or multiple etiologies, which I will discuss in the next slides, and followed by Japanese encephalitis virus, dengue, chikungunya, leptospirosis, and there are other causes also, but not too much because of them. So before we go ahead, second question, what is the microbiological diagnosis of choice for diagnosing scrub meningoencephalitis? Well, yeah, that's a tricky one. There's no correct answer for this. Let's see. Let's go ahead. So before coming back to, right, many people say CSF IgM ELISA and serum IgM ELISA. We'll talk about it. So if you remember the last slide, I spoke about multiple positives. 14% of the etiology was multiple positive. And this is one of the challenges we've observed in our study. We have so many combinations: scrub typhus, dengue, scrub typhus, chikungunya, dengue. We really can't make sense of what it is. Is it really dengue? Is it really scrub typhus? So the ambiguity that multiple positive, or the challenge that it creates is real, and we thought there has to be some system to kind of help at least reduce the ambiguity, if not completely solve it. So we came up with this diagnostic strategy, which was already there by Granerod et al. We inspired by her and her study. We performed additional tests, that is CSF, IgM ELISA, and PCR. And instead of just relying on serum IgM antibodies, we wanted to see what results come out of these. And we tried to, differentiate these patients into confirmed, probable, and a possible etiology. So this is something which is already published. So in the first 2 years of the study, we enrolled around 376 pediatric patients, and a positive serum IgM ELISA was found in 86 of the 376. However, 45% of these had co-positivity for another pathogen. We performed some additional tests, and what we saw was, on performing the additional test, that is CSF, IgM, ELISA, and PCR, and adopting the diagnostic strategy, it helped in differentiating the certainty of association of these 87 AES strep typhus cases into 16 cases with a confirmed association, 55 with a probable association, and 16 with a possible. So this kind of gives a hierarchical thing to the clinician that, this probably is a confirmed scrub typhus. So let's just focus on this instead of focusing on, or, while focusing on others as well. The other thing that we also did was to check for the diagnostic accuracy of CSF IgM compared to PCR. And it did give quite a decent accuracy, sensitivity of 93% and specificity of 82%. Additionally, the sensitivity and specificity of CSF IgM in patients with a proper brain infection, that is meningitis, encephalitis, or meningoencephalitis, sensitivity was good, specificity not that good. However, we had a very small sample size. Similarly, we performed CSF IgM ELISA for other causes, not only for scrub typhus, for dengue, for chikungunya, leptospirosis. And we, using the diagnostic strategy, we also, tried to solve the multiple positives. And using the diagnostic strategy, the the ambiguity reduced from, if I may say so, from 14% to 7%. So it did kind of give some kind of clarity, adopting a diagnostic strategy. So this is just last slide. And briefly, the challenges in diagnosing and managing AES in India based on my experience and my study is the first challenge is that all of scrub typhus, dengue, chikungunya, they're all endemic in India and they have overlapping clinical presentations. This is one challenge. So you cannot just clinically suspect. Eschar, which is pathognomic for scrub typhus, is present in only 4% of the cases. So there's really no differentiating factor at clinical presentation. Similarly, there are limitations in routinely employed microbiological tests, which is serum, IgM, ELISA. As you've seen in my previous slide, cross-reactivity may cause, dual positivity, or there can be a real multiple positives. We've had cases with confirmed chikungunya as well as scrub typhus, confirmed chikungunya as well as dengue. But we only got to know that because we performed a PCR. Again, there is limited availability of tests, only possible in tertiary care centers, not available in secondary care centers, where patients land first in. In tertiary care centers, there is late presentation in the hospital. In our experience, it's more than 7 days, more than a week, and the sample collection is even later. There is still, even though we used an extensive panel, etiology is unknown in around 50% cases or more. And although we've seen that scrub typhus is a major contributor of AES in this part and many parts of the country, there is lack of practice of evidence-based medicine so far. We still rely on ceftriaxone and acyclovir in many centers, and we still have to catch up to practicing evidence-based medicine. There are few ways that we could address these, and the few ways are development of a clinical prediction model or clinical scores that will not replace diagnostic tests, but at least point towards a probable or etiology, and you can just confine your testing to 1 or 2 pathogens instead and make it more cost effective instead of doing a whole panel. This is one of the main objectives of my ongoing study. The second thing that Bhagteshwar also spoke about is metagenomic sequencing, if not for individual samples, at least combine samples and do a kind of group testing to see if you're not missing out on some important pathogens which are not yet looked for. And identifying inflammatory biomarkers, which can potentially help facilitate rapid diagnosis. In our recent study, we saw that compared to viral, and when we compared between viral and scrub etiologies of AES, there was elevated serum CCL11 and CCL2 in viral etiologies. Also, age more than 3 years in children presenting with acute encephalitis syndrome and having serum levels of CCL11 less than 180 picograms per ml effectively distinguish scrub typhus from other causes. Again, Bhagteshwar spoke about this, identifying blood-based host signatures, which will, then you don't need to do a CSF lumbar puncture. Maybe we don't know yet, but it's still one of the things that host gene markers can kind of complement pathogen-based tests. So, yeah, thank you so much. And I would like to thank my funding agencies, India Alliance and Encephalitis International, my collaborating institutes in Bangalore, St. John's, Indira Gandhi, Bangalore Medical College, NIMHANS, my host institute, and University of Liverpool, and all my mentors and guides and my colleagues. Thank you so much.
Thank you, Tina. My apologies. I was supposed to introduce you, Tina, and I didn't. And you've just, introduced yourself as the Wellcome DBT fellow who's completing a fellowship soon and based at the National Institute of Mental Health and Neurosciences in Bangalore in India, and that you're a microbiologist and virologist and clinically trained, but also focusing mostly on encephalitis and possible encephalitis among children in the south of India, using a variety of tools. Thanks very much for that. And that was a focus on India, and then somewhat a focus also on scrub typhus. I'm going to now just introduce Rafael Franca, who's thank you, who is principal investigator and a senior researcher in virology at FioCruz, and is currently based across between Sao Paulo and Pernambuco, or in the city of Recife in the state of Pernambuco in the northeast of Brazil. Rafael's worked on various areas of virology, but including viral immunology, and will talk to us a little bit about a little bit about serological testing, as well as the brain infections global study, and how he led that in Brazil.
Okay, thank you very much, and thanks for the opportunity to present this perception of brain infections global, consortium, a project that we made in Brazil. So that the project was aimed to improve the diagnostics of brain infections in Brazil, especially. Just to let you know, I'm Rafael Franca. I'm a virologist from FioCruz. FioCruz is the largest research institute in Latin America. FioCruz is also directly linked to the Ministry of Health and the National Public Health System. So our aim is to provide improvements in the national health system. Next slide, please. So just a brief introduction about the Brazilian health system. There is the private system and the public system. So the system works essentially, there is a public and private. So the public system, named SUS, or Universal Health System, provides access to hospitals, diagnostics, and treatment for a large proportion of the population. Actually, around 9% of the Brazilian population relies on the use of the public system. And of course, this represents a challenge when you have a large proportion of the population seeking medical care. You have overcrowded hospitals and many gaps and many things that needs to be improved. Thus, the public system is always overcrowded and lacks resources. This limitation includes long wait times for appointment and treatments, shortage of medical supplies, and inadequate staffing. Consequently, patients often experience delays in receiving essential medical services, which can lead to worsening health conditions and increased pressure on the health system. So efforts to address these issues are ongoing, but they require substantial investment and strategic planning to improve the overall efficiency and effectiveness of the public health system. And of course, this project is very convenient because we're addressing one gap in the national Brazilian health system, that is brain infections. Next slide, please. In addition to the national health system, there is the Brazilian National System of Public Laboratories, which means complex exams or assays are usually forwarded and centralized. So this is a map of Brazil. You can see all the 26 states, and each state has what's called a LACEN, or a central laboratory. These laboratories are usually a single building in a city, a capital city actually of the state. And all the samples are usually forwarded to these laboratories to perform molecular tests, for example, PCR, and other more complex tests. And of course, this represents a gap, a challenge to the health system to archive the correct diagnostics in proper time. And additionally, the logistics of transporting samples and ensuring their integrity during the transit add to the complexity of the diagnostics process. And of course, this project was made to try to improve, at least locally. This was done in northeastern Brazil, as the state of Pernambuco. And so, okay, this is a cool question. What's the most common neurological manifestation of Zika infection in adults? Actually, Guillain-Barré is the most common reported neurological sign, neurological disease of Zika infection in adults. This was done through a project where we found and researched the neurological disease of Zika and chikungunya infection in Northeast Brazil. We found that a large proportion of the patients with neurological disease admitted to a hospital, a neurology service, reference hospital in the state of Pernambuco, a large proportion of those patients had evidence of arboviral infection. And of course, if you remember, Brazil has facing a triple epidemic with Zika, chikungunya, and dengue virus infecting the population, causing large outbreaks. Next slide, please. And from this project, we learned that most of the cases diagnosed with chikungunya were related to central nervous system infection. And the most common reported syndromes were meningoencephalitis on chikungunya monoinfected cases and myelitis. On the other hand, Zika was related to an increase in the number of peripheral neurological disease. For example, Guillain-Barré syndrome that was saw in a large proportion of the patients. And the Zika, chikungunya, and dengue infection are usually diagnosed by presence of viral RNA or specific IgM antibodies in the serum or CSF. And this is an acute infection. Of course, IgG you can use to track the past exposure, but usually in the central laboratories, samples are forwarded to diagnostics of arboviral infection, usually using real-time RT-PCR or serological tests that search for IgM. Next slide, please. So the BI Global, or Brain Infections Global project, was done in 2 hospitals in Recife, northeastern Brazil. The first one is a large hospital, is a reference hospital for neurological disease in the state of Pernambuco. And the second one is a smaller hospital called Correia Picanso that it's a referral center for meningitis and encephalitis. So this project was developed in these hospitals where we searched and we looked at the patient during a sample journey and all the history and the management of patients with acute brain infections to try to identify gaps and the steps that could be improved in the process of brain infections. Next slide, please. This graph shows that a large proportion of the brain infections of these in Brazil, especially actually from these 2 hospitals, were not known. So we can see there's dengue cases, chikungunya, HSV, which a large proportion of cases being infected, being diagnosed as HSV. Other bacteria, but most of the cases, almost 8% of the cases were unknown, or they lack a laboratory diagnosis of the cases. And this significant find highlights a critical gap in the diagnostic process for brain infections. Besides the laboratory, we also assessed the clinical practice, patient journey, and sample journey to understand and identify potential gaps on this process in those hospitals. Our assessment of clinical practice involved reviewing the protocol and procedures used by healthcare professionals to diagnose and treat brain infections. Of course, we looked at how medical professionals collected patient histories, performed physical examinations, and utilized diagnostic tools and tests. Next slide, please. Based on this, we proposed what was called an intervention plan. From these 2 hospitals, there are the demographics of these hospitals. The first one, a large hospital with 830 beds, and the second one, much smaller. But we proposed components on the intervention and based on major key points. We implemented external quality assessments to the clinical laboratory, participant centers. We provided acquisition of minor equipments, for example, fridges, microscope, centrifuges. We also helped the laboratory, the hospital laboratories, to revise the protocols, including a number of tests that were done. And the clinical components revised the meningitis flowchart or algorithmic guide at the Secretary of Health. And we provided that revisited the protocol aimed to improve the clinical management of these patients. And to achieve this, we organized workshops, including clinical and laboratory components as a program on actualization or an update program in quality control and medical and clinical protocols. Next slide, please. So these are some pictures of the workshops we organized in Northeastern Brazil. So the first one was a workshop on brain infections that was done in a local hospital. The second one in the participate centers, for example, Hospital da Restauração, where the residents were trained and we have discussions about how to improve the diagnostics of brain infections. In the last picture, we can see it's a meeting with the Secretary of Health, where we presented all the findings and the revisited protocols and algorithms with the aim to implement this at the state level. At the state level, we're talking about a population of about 9 million inhabitants, the state of Pernambuco. Next one. Thanks. So this is the revisited flowchart of the brain infections, meningitis, and encephalitis cases, and how to treat and how to manage and which tests should be done at the local setting. Of course, we consider the local settings, for example, the necessity of testing for arboviral infections, the prevalence of bacteria and other pathogens that would be more significant to the Brazil setting. And we provided a very proactive approach to disseminate our findings and recommendations by presenting this version of the protocol. This presentation was delivered, as I say, directly to the State Secretary of Health, ensuring that the key decision makers were well informed and empowered to implement necessary changes in healthcare policies and protocols. Next slide, please. And here we can see this protocol was actually approved and implemented in the hospitals. We can see this protocol was printed and sticked in the walls of the hospitals. There are different rooms in the hospitals, but we can see that the clinicians, they were aware of the protocol. These include not only the clinical, but the laboratory is more complicated, more detailed protocol. And just the previous slide, I just showed a brief version of the protocol, but we included laboratory protocols as well. But this was very well accepted by the clinicians, and they started to use the protocol right away. Next slide, please. So regarding the laboratory capacity training, we did workshops focused on training the laboratory personnel. So we can see here pictures of laboratory people attending a workshop with a CSF specialist that explained how to better perform CSF analysis, for example, cell counting, grain stain, and which tests are useful for detection of pathogens. And on the left side, you can see, on the right side, sorry, you can see a laboratory for CSF flow chart. So we stick that on the hospitals as well, and we informed which tubes should be collected, how much and how many tubes, how much volume should be collected, and where to forward the samples for the proper laboratory diagnostics. And on the top of that, next slide, please. There is a poll question. Which of the following is not considered a definitive serological diagnosis of CNS infection? Okay, this is correct. Detection of IgG in serum is not considered a definitive serological diagnosis of CNS infection. So next slide, please. In addition to the pathogen detection and the laboratory capacity training we performed in the hospitals in Brazil, we put FioCruz as a support laboratory for the diagnostics of commonly or important pathogens in the Brazil setting. We made on the left a form that the clinicians could fill with the name of the patient, some basic information, plus the assays that they required for that sample. And we included here the three main arbovirus circulating in Brazil, the virus, dengue, Zika, and chikungunya. as well West Nile and other important pathogens, for example, herpes type 1 and 2, CMV, varicella zoster virus, and enterovirus 71. And from the samples, a few samples we tested, not all the samples that was, or the patients that were included in the study, but we can see from 95 samples we tested, CSF samples, we molecularly detected 3 positives with HSV2 infection, 1 HSV1, streptopneumonia in 1 positive, CMV 1 positive, and we increased the total number of positive samples by 6%. That was much bigger than the previous data we found in the hospitals. And considering just the laboratory cost per patient, we estimated that in Brazil, molecular testing using this panel would cost around $100 per patient, which is not a high value. Next slide, please. And to close my presentation, just the last 2 slides. We can see here the epidemiology of meningitis cases in Southeast Brazil, and this is replicated all over the territory, the Brazilian territory. We can see there's a lot of cases being reported as bacteria. We can see on the left the description of the bacteria, for example, meningococcus, pneumococcus, but there is no description about the viral infections or viral meningitis or the cause of viral meningitis. We can see on green on the left, there is the number of cases reported per year related to viral meningitis, and none of those cases had the pathogen identified. This is more common. The identification of the pathogen is very common for bacteria, but is not for viral infections in Brazil, which is challenging given that Brazil is facing the recurrent outbreaks of different virus since the last decades. Next slide, please. And here, just to show in the municipality of Ribeirão Preto, a small city in São Paulo state, we can see here on the left the number of cases reported in 2023. We can see most of the cases of meningitis cases were caused by viral infection, and the pathogen was not identified on those cases. And we can see there is since 2013 or 2014, there has been an increase in the number of viral meningoencephalitis and meningitis cases in Brazil. And this is happening in different cities. And you can see on the other graph that bacteria is usually identified, but in gray you can see these are meningitis caused by bacteria with unknown bacteria or no definition of the causing agents of those cases. And I think this is it. I just realized I forgot to make the last slide, the acknowledgement slide, but I would like to acknowledge Dr. Bhagteshwar and Dr. Franklin for the opportunity to present this data. I think this is it. Thank you.
Okay, thanks so much, Rafael. I think we're going to just open up to questions. I think there've been a couple of questions in the chat, and I've tried to respond to those. But please put more in. In fact, so I think perhaps the Q&A section is where ideally we put the questions, and then we can answer in there. But we can answer verbally, and maybe I can then direct questions to individuals who'd be best placed, whether it's Tina or Rafael, and then maybe I can answer some in writing within the Q&A box. Okay, well, actually, we've got a question here, and maybe Tina, this one might be for you. So, what are the possible pathogens causing multiple brain abscesses after freshwater drowning? I don't know if you'd like to take that. I can answer as well if you like.
Yeah, correct me if I'm wrong, Bhagteshwar. Naegleria and your so yeah, that acanthamoeba, Naegleria can cause due to drowning your brain infections and brain abscesses. Are there more? Do you want to add or correct me?
I guess just in those situations, I think they're relatively rare pathogens overall. Sometimes that's because, as one of our colleagues in the chat has said, how would we diagnose CNS infections caused by entamoeba species? All of these amoebae are very difficult to diagnose. Ideally by microscopy, but they're not always present within the CSF that you might have to hand. They can be quite variable in terms of their presentation, and I think there are a few PCRs or serological tests that are clinically validated for use. I believe some are available from CDC, and there must be some in other reference labs as well. But within, for example, a district hospital, it might be difficult to diagnose them. I would just say also that there are bacteria that you can find that are less rare and less interesting perhaps than these things. And I think one of the more recently ones that's associated with this is, if I'm not mistaken, Enterococcus avium is something that is increasingly found in brain abscesses where there's a history of swimming, not necessarily drowning. So I think another question. So I know there are many in vitro diagnostic PCR multiplex assays, but I was wondering if you guys know of any assay that can be used for serological testing of IgG and IgM for a large panel of pathogens. Tina, Rafael, either of you, I think, could answer this.
I can't think of anything apart from the rapid tests available for dengue, which has IgM and IgG only for dengue. Yeah, I can't think of anything. I'm not aware of anything.
Rafael, I know you follow serological testing quite a lot. Is this something that might be available soon? Multiplex serological testing assays?
There are lateral flow assays that you can discriminate between IgM and IgG for dengue, I saw, but I don't know the specificity and sensibility of those tests, if they're good enough, but they are.
Sure, thanks. And I guess I have heard about some of these tests being developed, but I don't think any of them are actually available commercially just yet. But I know there are some multiplex assays, up to 50 different antibodies could be tested with them, but they're currently in the being developed and tested out. And aren't available just yet, but hopefully will be available at some point. Those issues we talked about in terms of cross-reactivity and maybe just being there in the background might factor in quite a lot, though, when you go fishing for multiple antibodies. Just very briefly before I hand back to Franklin, in terms of strep pneumoniae diagnosis varying demographically, the short answer is yes. Immunosuppression, extremes of age, either younger children or older adults, tend to be where you get more pneumococcus diagnosis. And of course, in patients with advanced HIV, disseminated pneumococcus is much more common than in immunocompetent adults. But back to Franklin, please, for a roundup. Thank you, everyone.
Thank you, Bhagteshwar. I'll just quickly run through some of the opportunities that we want to share with you. But thank you. We'll just use the opportunity to thank all our speakers, thank the chair for this wonderful section, and the amazing breakthrough that you guys are doing in terms of solving challenges with brain regards to brain infections. So it's time for us to share our opportunities. And so if you or your team, you have any way to showcase what you're doing to improve brain infections in your setting, then please do submit a 3 to 5 minute video on this website. You can scan the QR code now of you doing that, and that will enable you to win a prize to attend the Neuro ID course, which is hosted at the University of Liverpool next year in June. And that award covers of up to $1,400 US, which is for you to registration of your course and to take care of some travel expenses. So please, the deadline is June 30. If you have any means of showcasing that, please do submit a video. And then there's a McDonald 2-year research fellowship, which you can find the details on your website. So on this slide will be shared, there's a hyperlink to all of these opportunities that we're presenting today. So for this one, the closing date is 30th of June. You must be based in a low and middle income country, and it's a 2-year for you to carry out any research related to multiple sclerosis. And then the next one is the Cardia Advanced Neuroscience Imaging course, which will be taking place at the University of at the Bordeaux School of Neuroscience. So they have a stipends of to 3,950 euros to help you to cover the cost to attend this training in neuroimaging. And I think they've highlighted that the course has to do with microscopy, where it gives you advanced knowledge on capturing imaging and analyzing them. And then the next one is the remote mentoring scheme for those who are based in LMICs. This takes place all online, and it is for 12 months. And this is by the THEET network. Applications will be opened on the 5th of November. There's an award of up to 3,500, where a head worker based in LMICs will be paired with a UK head-based worker for mentoring with regards to head-related problem and research in the health setting. So please do watch this space if you're interested to going into this mentoring scheme. You can see more details on their website. And lastly, there's NIHR Global Advanced Fellowship for those who have a PhD, or if you have a medical degree and a postgraduate degree, you're eligible to apply. But this research must be done in a LMICs institute. You can be based on a LMICs institute or in the UK, but the research output is to address challenges in health and care in the LMICs setting. So you can find more details on their website. The closing date is 11th of July, and you're giving up to £750,000 for health-related issues. We also like to plead with you, if you just take 5 minutes of your time to go through our survey. You can scan this QR code now, or you can visit our website for us just to let us know how any of this session has helped you change any practices in your setting. And then lastly is just to let you know that we have a new website which has a lot of resources, the Neuroscience Research Unit at the University of Liverpool. And then our next session will be on the 28th of June, same time. And the title will be on Data Saves Lives, where we're thinking how we can partner with industries and use AI to improve brain-head infection. So please do note that this date, and we hope to see you all in our next session. So with this, we just want to thank our funders and thank you all for making our time to attend our session. Hope we're going to see you in our next session. Thank you.